Welcome to today's HealthLine Innovator webinar from the American Association of Kidney Patients, titled Dialysis Access Options and the VasQ Difference. Thank you for joining us today. My name is Jerome Bailey, AAKP's Director of Patient Engagement and Advocacy, and I'm pleased to lead today's webinar. AAKP launched our Innovator webinar series as an extension of our normal HealthLine webinar programming. The content of this program, as presented, and sponsorship support of this webinar is provided by Laminate Medical Technologies. As the nation's oldest and largest patient-led kidney patient organization, AAKP is proud to host this innovative webinar for the growing global community of patient consumers and families, clinicians, researchers, and policymakers seeking the latest advances in kidney care. AAKP is a steadfast champion of innovation that challenges the status quo and advances patient choice, outcomes, and quality of life. While this activity is an improved educational and informational webinar containing branded content, AAKP does not endorse specific commercial entities or products. Thank you again, Laminate Medical Technologies, for supporting today's program. AAKP's HealthLine and HealthLine Innovator webinars fall under our Center for Patient Research and Education. We believe patient and care partner education is an integral part of an individual's treatment, and to that end, AAKP is a champion for full patient care choice, the protection of the patient-doctor relationship, and the elimination of artificial barriers and government determinants of health that impede patient care and access to available treatment options. Through our initiatives, we aim to make sure patients have a central voice in research and innovation. By leveraging lived experiences and unique insights from the kidney community, we help drive meaningful advancements across the entire product development lifecycle, from clinical trials and regulatory processes to payment decisions. As medical science progresses with personalized medicine, cutting-edge technologies, and novel treatments, the potential for better outcomes in kidney care has never been greater. Today, we're focusing on an issue that is critical to both patient health and quality of life: dialysis access. Your access site, often called your lifeline, is where blood is safely removed and returned to your body during dialysis treatment. Traditionally, patients have had four main options for access: a fistula, a graft, a subcutaneous device, or a catheter. Thanks to ongoing innovation and advocacy, new and safer devices are becoming available, giving patients more choices and the ability to select the option that works best for them. Today, we'll highlight one of those innovations, a device called VasQ. Before we introduce our speakers, we want to share some powerful insights we gathered from individuals like you ahead of today's event. To kick things off, it's my pleasure to introduce AAKP's Vice President and Chair of Policy and Global Affairs, Paul Conway. Paul is a passionate advocate for patient-centered care, patient participation in true shared decision-making, and the use of patient insights in kidney research. As a kidney disease patient himself for 47 years and a 28-year transplant recipient, he has been recognized for his advocacy work with several national awards, including the President's Medal from the American Society of Nephrology. Professionally, Paul has served in 4 U.S. presidential administrations, including as Chief of Staff for the U.S. Department of Labor. As part of his advocacy work, he was selected by the FDA to serve as the inaugural chair of the FDA's Patient Engagement Advisory Committee and has served on the American Board of Internal Medicine Nephrology Specialty Board, as well as multiple CMS technical panels related to dialysis quality improvement measures. Through AAKP's Center for Patient Research and Education, we conducted an independent flash survey to get insights into people's understanding of the importance of selecting the right dialysis access for them and how satisfied they are with their current access. Paul is here to share the results from this flash survey. Paul?
Thank you very much, Jerome, and thank you to all those who are watching. The issue of life-saving dialysis care and the access that people use to stay alive and to stay connected to their therapies is critically important to AAKP. Many of us know the fact that in the field of kidney disease and kidney treatments, very little innovation has happened. It's why AAKP is such a champion when new innovations come along that make a difference in the lives of patients and that specifically address those issues that patients are most concerned about in regard to their care. So the insights that we're going to share here directly support this issue of patient insights on dialysis access options. So we asked folks what type of dialysis access options they've had experience with throughout their journey on dialysis. And it's very interesting. AV fistula, the surgery on blood vessels that connect the artery to a vein in the arm, 77% have experience with that. Central venous catheters, 48% had experience with that. AV grafts, 32%, and peritoneal dialysis catheters, about 32%. So you can see here across the spread of those who participated a wide range of experiences and insights. We asked folks when they received their current access. 38% said after first having a dialysis catheter, 32% said prior to needing dialysis, and another 30% said after an access option failed. These numbers are important because they capture the reality of a patient experience. Most patients find out that they're going on dialysis from an emergency room setting and they go on via a catheter. Others, about a third, try to be proactive in their care and get the access before they need dialysis. And you can see that reflected in these numbers. And 30% got another access after an option failed, which is not atypical in the experience of a dialysis patient. We asked, have you spoken to a healthcare professional about the advantages and disadvantages of the current vascular access options for dialysis? About 73% said yes, 26% said no. And I would focus you on the 26% who said no, because our goal through this webinar today is to engage patients and their loved ones on asking questions of healthcare professionals about exactly what are the advantages and disadvantages of different vascular access options so patients can exercise informed choice. We asked, when your current dialysis access was created, did you feel like you knew your options and were an active participant in the decision-making process with your kidney care team? These are pretty telling results. For those who knew their options and they felt like they were an active part, it was about 55%. But in the next three questions here, you can see where patients said they didn't know what their options were. They didn't feel like they were included. That's about 18%. Somewhat knew their options, but still didn't feel like they had any decision-making power in the process. That was 14%. And somewhat knew their options, but still felt like they were not part of the decision-making process. When you roll up those last three, you get 26, about 44% felt as though they really didn't know what their options were and they were not part of the decision-making. AAKP stands for patient empowerment. These are important access issues. This is your life-saving treatment. We think patients ought to be fully involved in the decisions that are made about access, and we think that they should be provided all of their options, including the most cutting-edge and new innovations that are approved by FDA and entering into the marketplace. We asked folks if the cost of procedures or care affect their choice of access type. And this result is very interesting. 2% said yes, 9% said somewhat, but 89% said no. This is an important insight from our perspective because what it means is that patients want the best available access because it is life-saving dialysis. And they want that access which best positions them to get the best treatment at the lowest risk of complications or infection, and that the price point is secondary. We fully agree with that as AAKP, since it's a life-saving technology and it's a access for you to use to maintain your life and your lifestyle and your income for those who can continue to work. It's critically important that it's the best. Our next question, we ask for those who currently have an AV fistula, what has been the most frustrating aspect of your experience? This was also very important for us to see. One of them, the largest group, 46%, indicated multiple procedures and interventions was an issue. Cosmetic issues or impact on self-esteem. This is especially true on forearm placement. 18% indicated that. Communication with the care team, how it all comes about, the process of it, 12%. Only 11% said they had no frustration. But the top one here is probably the most indicative and the one that is most known to patients, because we all talk to each other. And that's the process that you have to go through multiple procedures and interventions to get it right. We asked, have you had surgery to treat complications related to your current type of dialysis access? 52% said yes, 48% said no. We asked folks if they believe there's any value in a vascular access that prevents needle injury, such as bleeding and hematomas or pseudoaneurysms, the large bumps that you see on a lot of folks' forearms, or bleeding from accidental needle dislodgement. 69% said yes, 6% said no, 25% said unsure. Clearly, you can see the majority of patients think that if there is a better technology and a better way of doing vascular access that prevents some of these conditions, there's great value in that in the viewpoint of patients. And then we asked, do you feel there is a value in vascular access that could ensure successful needle access to the bloodstream for treatment every time? So reliability as an issue for patients. 83% said yes, only 5% said no, 12% said they were unsure. In summary, these insights provide a very important data set to understand the issue and why patients are interested in innovation for how they connect to life-saving dialysis machines. We're very excited about this webinar. We hope it's informative to patients and to caregivers and even to professionals. Because if you take a look at those numbers about patients who felt like they were not engaged and they did not have a role in the decision for access, that's room for improvement. Also, room for improvement is the area where patients just simply may not know what the new innovations are, or that innovations are out there that reduce many of the common complications that people have. So we're proud backers of those who are in the arena fighting for patients to provide new products, and we can't say enough about it. We appreciate those patients that participated in our survey and shared these insights with us today. So Jerome, let me throw it back over to you. Really looking forward to this. Thank you.
Thank you, Paul. These survey results give us a roadmap for what patients value most and where healthcare providers and advocates like AAKP can help fill the gap. It's now my pleasure to introduce our first presenter, Dr. Keith Ozaki, Professor of Surgery at Harvard Medical School and Director of Vascular Surgery Research at Brigham and Women's Hospital. As a leading vascular surgeon and scientist, Dr. Ozaki performs over 250 complex vascular procedures each year and has co-edited Master Techniques in Surgery, Vascular Surgery. He is a National Institute of Health and American Heart Associated funded investigator whose research focuses on translating novel vascular technologies from bench to bedside with the goal of improving vessel healing and function. Doc, I turn things over to you.
Thank you, Jerome, for that kind introduction. And I appreciate the invitation from AAKP and Laminate and the opportunity to speak directly to patients about something I'm passionate about. Let's kick it off. So today I'm going to give you a little discussion on hemodialysis access. These are my conflicts. And as you can see, I've done a lot of work interacting with various industry partners because this has been my academic focus and passion over the last decade. As you know, end-stage kidney disease in the United States is an increasingly important problem for our society. There are over 800,000 patients now needing renal replacement therapy, and almost 2/3 of those patients get hemodialysis. That is going to be the focus of my talk today, and that is my area of clinical expertise. As far as hemodialysis, there are really three different types of hemodialysis that we deliver this therapy to patients. The first is the arteriovenous fistula. That is creating a connection between your own tissues, or autogenous access. That's what autogenous means. We connect the artery and vein in your own body without artificial materials. The next is an arteriovenous graft. This is a prosthetic or artificial material that is inserted between the artery and vein, and blood flows through this artificial surface. Sometimes this is PTFE or polytetrafluoroethylene, same thing as Teflon, or it can be what's called a biologic or synthetic one, where they take things like the artery from a cow and use that for implantation. And the final type is the way that most people start their dialysis. That's a catheter, and that's actually a plastic tube that is inserted through the skin, and it goes down into the blood vessels, and it has two ports, one for removing the blood and one for returning the blood to the body. Dialysis access has been termed a kingdom of the ruins. It is really, really one of our worst operations when it comes to outcomes. And believe it or not, there's been very little innovation over the last half century. Here's a picture of the first arteriovenous fistula constructed in the mid-60s. We basically then sewed the radial artery and the vein together. We used a little monofilament or like fishing line material to sew those together. We would fill to make sure that there's good thrill or flow in the blood vessel. And after a few weeks, you could use this for dialysis. Here's a picture of a fistula that was performed in our hospital just a couple of months ago. And look at the differences. This one, 60 years later, what has truly changed? Well, the photos in color. That's about it. Very little innovation in that space. Let's now drill down a little deeper on the different types of access. Catheters are the highest risk access, and they are certainly the most expensive approach. Patients can't shower, it's very inconvenient, and these catheters are very prone to infection and forming clots and scars in the blood vessel in the chest, and this has real long-term consequences for patients. Well, what about infections? Well, really, infection is something all end-stage kidney disease patients should fear. In reality, it's the second most common cause of death in dialysis patients. Whenever you actually look at the risk of an infection associated with dialysis access, it's almost 33 times more likely to happen than a fistula for non-tunneled catheters, 13 times more likely for tunnel dialysis catheters, and even if you have something completely under the skin like an artificial AV graft, you're over 2 times more likely to have an infection complication if you have a graft compared to your own fistula. The next type of dialysis access that I mentioned was this AV grafts. These are very high flow accesses whenever you first place them. But as I mentioned, they're prone to infection. The high flow also means that this may make a patient's arm a little bit more prone to swelling and blood flow issues that can lead to bad blood flow to the hand. While they work well initially, these do have a high risk of clotting and wearing out after the first few months of use, and that can lead to several procedures to continue to keep these usable. And now let's talk about AV fistulas. This is my preferred form of access. However, these certainly are not perfect. They can take many months to mature. And in fact, I tell people that this can take 4 to 6 months to mature, and 4 out of 5 people need another procedure to get it to mature. Over the long term also, I'll talk a little bit about a special issue with these, in that sometimes they start to have too much flow. And many of you have probably been in a unit and you see patients with very large bumps in their arms, and this could be secondary to a high flow fistula. Whenever you actually have a fistula placed, multiple studies have shown that only about 60% of these end up being usable at a year. And really, this is only slightly better than flipping a coin heads or tails as to whether this operation will work for you. This is certainly an area for a lot of improvement. And even after I place a fistula, there are all kinds of things that can lead to procedures needed to get that fistula to work. And many of you have been through this whole long algorithm to try to get a fistula to work. In one of our recent series, most patients needed over 2 procedures in the first year to get their fistula workable. So, whenever you establish an access and whenever you maintain permanent hemodialysis access, it's not a one and done procedure, but really it's a long-term commitment to a program to maintain your dialysis access. Unfortunately, in this field, complications are very frequent. There's been a push for patient benefit to use more fistulas, and this is some data we recently published looking at the last decade of what people are actually doing in the United States. And you see AVF in the form and AV graft, AVG, in the form versus the upper arm. And we really have tried to push people to do more fistulas in the form, but you see that green line right in the middle, it has essentially been flat. You also see quite a few patients still getting AVGs, the arteriovenous graft, the less preferred form of access. One other thing we've learned about fistulas is, like many things in surgery, the more your surgeon and team does, the better they tend to get at it. On this graph, in the horizontal x-axis, you see basically the people that do the most fistulas on the far right and the teams that do the least on the far left. And the more you do, the more likely you are to get a fistula to mature. Due to these challenges in fistula maturation, groups like Laminate have developed devices to try to improve fistula maturation. And in my career, the VasQ is really one of the first novel fistula maturation adjuncts that has gained FDA approval. In this slide in the red, you see our traditional numbers that only about 60% of fistulas actually mature by 1 year to usability. And this is over several studies in multiple countries. On the right side, you see a lot of different reports of fistula maturation with the VasQ device. And this is from several countries, including the United States, which is on the far right at 88%, which is an outstanding result using this device as an adjunct to help fistula maturation. However, this maturation rate really takes a lot of work and a lot of team effort. I'm going to tell you a little bit about our practice here at the Brigham and Women's. And here you see the type of AV accesses, autogenous or a fistula, or the non-autogenous, a graft. And in the yellow here, you see that our fistula rates are actually about 90% over time. And this number actually includes some people that were in studies looking at new graft materials. So we really are big fans of fistulas, and we are definitely big fans of anything that can help that fistula maturation and lower the number of procedures that we have to do to get that fistula usable. I will also give you a big qualifier to what I'm talking about today. And one of the joys of my life is I get to go to the Caribbean and teach other surgeons about how to do dialysis access, and also learn from them as to how they're able to plant dialysis access and make it usable. And I'm blessed here in Boston. I have a team of people that can do very advanced endovascular therapies. We have a system where we're able to cover patients 24/7. This may not be true even across the United States. And so you do really have to look at the overall landscape of what's available to you and go with the best team that you're going to partner with over your lifespan to ensure that you have that lifeline hemodialysis access plan set. This is a chapter we recently wrote on creating dialysis access fistulas. And this is kind of, I think, testimony to the expertise, not just of me, but people like those in this picture that are around me, and how our team approach really has kind of driven much of our outcomes for our patients. One of the things I mentioned is too much flow over the long term can be harmful to a fistula. And that's why your team frequently will push you to go to a lower flow fistula down near the wrist in the forearm. If you do get a fistula that over time has too much flow, this can lead to complications such as arm swelling, hand blood flow problems, those big bumps or aneurysms, and extra bleeding after your needles are taken out. This also leads to scarring up in the chest, And there's been some concern about heart issues. And so I'm going to talk to you about something that is hot off the presses here as new data. This is something we presented just last week at the New England Society for Vascular Surgery, and we compared the lower flow forearm fistulas with upper arm fistulas in very big databases, and we linked it to big databases related to Medicare billing. And we looked at things like admissions for heart failure and heart complications, or needing to get operations for high flow, or even dying before someone seems like they should have died. On this graph, in the blue, you see those that had the forearm fistulas, the more beneficial fistula, and in the red, the upper arm higher flow fistulas. And we see this carried out to 30 months of time over the horizontal x-axis. And to be free of having those heart and death complications, the forearm fistula patients did much better, even though we control for many other variables in a study like this, really showing that long-term having a high flow fistula is not good for your heart and your overall body. One of the things I'm encouraged about is trying to elevate surgeons to go as distal as possible. Even though it's easier to make something in the upper arm, lower flow coming off the arteries near the wrist may be beneficial. And this is something I'm particularly intrigued about the VasQ device. Here you see a picture of this device because it really does constrain flow in the long term. And this is data that I think will be emerging in the coming years, that these fistulas will tend to last because they don't get the balloon aneurysm dilatation or maybe the heart failure and scar that we see in high flow fistulas. This device is very good at constraining and supporting the outside fistula shape. This is an ultrasound picture without the device on the left and with the device. And you see the bright white shadow there and the red lines on the right. And this shows that this constrains the overall blood flow going into the fistula and really has the opportunity, I think, to keep a fistula from becoming high flow in the long term. It's been a fun thing for me in my career to do a lot of basic research. And we try to understand how things like AV fistulas impact the blood vessel wall. And this is a picture of two different images of a blood vessel and how that wall vibrates over time when you create a fistula. In fact, about 15 years ago, we published a paper on how that push of the blood on the blood vessel actually can lead to a lot of scar formation and lead to the scar that leads to fistula failure. That's called intimal hyperplasia. So when I first met Tammy Gilon, the CEO and co-founder of Laminate in 2015, I was very excited to hear about her science behind this device because it exactly matched our research. And I told her I wanted to be a part of every clinical trial they did. And we were fortunate to be a site selected for those clinical trials. It's also been exciting for me to get this to the stage of FDA approval. And I look forward to continuing to work with her on a next phase trial, even a post-market study trial of this device in dialysis access patients. So now I'm going to turn things over to Tammy and her team so she can tell you some of the story of how we got to where we are today. Thank you.
Thank you very much, Dr. Ozaki, for the comprehensive explanation of the technology. I'm Tammy Gilon. I'm the CEO and co-founder of Laminate Medical Technologies, and I'm happy to share with you today the evolution of VasQ. How did it all start? It all started in 2012, where we came across the big unmet need for patients, which is the failure of fistula procedures, the gold standard of vascular access, that allows the patient to be on dialysis. The fistula is created in order to allow a lifeline for patient through dialysis. However, it fails in many of the cases, requiring additional interventions and complications. And our mission was to find the best solution that will address the root cause that lead to these failures and come up with the best solution for these patients that will allow stable and long-time dialysis. So the company was founded in 2012, and we started with some computational fluid dynamics work that would mimic the fistula area, the vein and the artery in a computational pilot that would show what happens there, what are the failure modes, why do the vein get stenosed and narrowed over time, and how can we solve these problems. We then moved to animal trials and started in 2014 with the first in human trials to test what the device looked like on patients. This was in 2014, 2.5 years after the company started. You can see in this animation video the VasQ device that is placed externally to the blood vessels and help the flow be more smooth uh, over time, reduce the stenosis, and shape the fistula in the right mode. The design features of VasQ that allow this improvement of flow is first of all to provide structural reinforcement against the vessel wall shear stress that is developing over time, a lot of tension that is developing on the vein. It also enables a tapered transition for less turbulent flow from the artery to the vein and retains the configuration post the surgery after the surgeon created the fistula over time. So the next step was to start gathering some real world data. When the concept was working and the clinical trials that started in the UK showed good directional results, we started to expand to other countries based on our CE mark in Europe. We then started a randomized control study in 3 different centers in the UK, which had phenomenal clinical results and opened the doors for a few additional users around the world. In 2019, we've started our pivotal trial in the US in 15 different centers across the country that were contributing to the enrollment of 144 patients. And as you can see, the RCT, the randomized control results in the UK, were very similar to what we've seen later in a bigger patient population in the US, very consistent results of having these fistulas functioning very well in the short term and long term. They were less likely to occlude, and the fistulas demonstrated higher usability at 3 months and 6 months. The pivotal study results, which was very aligned with that, showed that more patients were catheter free at 6 months, which is a big deal for patients. As you know, you can work and rely on these fistulas exclusively without needing a catheter. And there's overall success, which was much higher than the standard of care fistulas that were done by the same surgeons. Also, another benefit that we've observed that over time, these fistulas are less likely to develop aneurysms and high flow, which is a huge benefit for patients to reduce the requirement of making these fistulas smaller or fixing them over time as a result of an aneurysm. This study was published in one of the leading journals for vascular access. We then got our de novo FDA approval in 2023 in order to start commercializing the technology. And the next step was to make sure that we secure payment for this technology to allow access for all patients that are in need for this technology. We've worked with CMS for a few months, and in October of 2024, we were able to get Medicare reimbursement. So a specific code C8000 for VasQ that is covered by Medicare. Today, from a high level overview, we see that VasQ was implanted in over 4,000 patients around the world. There are 16 publications that are supporting VasQ and showing the benefit, all very consistent with the good results, and zero safety issues, which is very unique for a new technology and implant. We've seen zero safety events that put patients under risk. The rest of our mission is to allow as many patients as possible get access to these devices, as many surgeons to be educated with how to implant this device and get better fistulas, more functioning fistulas for their patients to be a standard of care in fistula creation. I want to thank you for your time today, for listening and learning about this important technology for patients.
Ozaki, for that insightful presentation and for sharing the important work Laminate Medical Technologies is doing to improve vascular access. Our audience members were able to submit a question to the panelists as they registered for today's event. I'd now like to ask Dr. Ozaki and Tammy some of those questions. We'll start with Tammy first. How can patients and providers find out if VasQ is available in their area?
So this is a very good question. You can get into our website, Laminate Medical, and learn more about the technology and the availability. If you have specific questions, you can fill out the form, insert your contact information, and we will be sure to be in touch and provide you with anything you need.
Our next question is for Dr. Ozaki. What factors do you consider when deciding whether a patient is a good candidate for VasQ?
To me, if there's going to be a patient that over the long term, I'm concerned about high flow, that's the kind of scenario where I think over the long term, that investment up front will gain benefit for the patient. For instance, any access coming off the larger brachial artery, that's a scenario I think is a good opportunity for it. I also think this device is very good about keeping extrinsic compression of that low pressure access from happening in that first couple of inches near the anastomosis, or where we connect the artery and vein. And sometimes patients have certain anatomic scenarios where that would be beneficial to use a device like this. And then finally, certain patients just seem to have a biology that's challenging. And if someone has already failed an access a couple of times, this may be a scenario where that extra push towards maturation would be a great scenario for this type of device. One of the nice things is we really haven't seen in hundreds of patients any big negative downsides to the patient for a device like this. So that really lowers my threshold for using it in various patients.
Tammy, hoping you can answer this next question. What advice do you have for patients who want to discuss this option with their care team?
The best advice would be learn as much as you can about your options, all the alternatives that you have in front of you. Discuss with your doctor about all the pros and cons of the procedure that is going to be created. What are the best chances for it to succeed, and if VasQ can be applied?
This question is for Dr. Ozaki. Are there patients who may not be appropriate candidates? And if so, why?
Well, there are a few things. I don't have them all memorized, but certainly if you're allergic to any of the metals in a device like this, I don't think that would be a good fit for you to have a permanent implant in a scenario like this. But most patients tolerate metals like this. These have been been shown to be very infection resistant, and they also tend not to tear apart over time. We've used these many times in the setting of inside the blood vessels, so they really do seem to be tolerated by patients quite well.
Tammy, how important is patient education and shared decision making in the success of technologies like VasQ?
This is super important and critical. The uptake of new technologies take years. It can take 5 to 7 years after a procedure or a device becomes standard of care. So your responsibility as patient is to expand the circles of information to make sure that your peers, your friends, your colleagues are aware of the options that they had, to make sure that we optimize treatment for any patient that is interested in that.
Dr. Osaki, what key questions should patients be asking their vascular surgeon when discussing fistula options?
Well, as I pointed out, it's important to have someone, hopefully, who has experience dealing with end-stage kidney disease and chronic kidney disease patients, and someone who's going to be available, someone who's a good listener, and someone who's really dedicated to making this happen for you. If you happen to get a team that has a lot of experience and a high volume, that's a very good thing. And also someone that's facile not only in open techniques, but also endovascular techniques. If not that individual, then someone on that team who can help you take care of your dialysis access.
And Tammy, what message would you like to share with patients who feel discouraged after multiple access failures?
Access failures can be very discouraging. This is the truth, but there are better options for you as patients. I encourage you to go see your doctor and ask them if there are better options and alternatives to make sure that they're getting the optimal treatment and increasing the chances of getting a functional fistula over time. You have to ask your doctor if VasQ is an appropriate option for you, because there are better options to create better fistulas.
Dr. Ozaki, last question. From a surgeon's standpoint, what are the biggest challenges you see in creating and maintaining reliable vascular access for dialysis patients?
Well, I think we really need to make sure that the expectation of a one and done is not there. And it's so disappointing to patients, even very disappointing to me personally, to do what I think is a beautiful operation and then they come back to clinic and it's not working. We have to go through this again. And so I find that good communication with patients is important. The frustrations of the biology and the clinical limitations we have. We're lucky to have several different industry partners who are really trying to push the frontiers to make our care better for these patients until we have other forms of renal replacement therapy. But for right now, I see hemodialysis happening a lot in our U.S. Patient population. And just understanding that it's not just one and done, but it's a part of a team and a long-term commitment to maintaining that permanent access.
I want to thank Dr. Ozaki and Tammy Gilon for those thoughtful responses to our audience questions. We appreciate you joining us today. I'm now pleased to welcome Eileen Dion to the program. Eileen is an ESRD patient who faced repeated fistula and graft failures that left her dependent on a central venous catheter as her form of dialysis access. When her physician suggested trying VasQ, she decided to give fistula creation one last chance, and it worked. Today, Eileen is catheter free, has reliable access, and is looking forward to a kidney transplant. In her free time, she enjoys cooking, coloring, and spending time with her family. Hello, Eileen. Thank you for joining us.
Hello, and thank you for having me.
Can you share what your experience was like dealing with repeated fistula and graft failures before you tried VasQ?
It was honestly very stressful learning that it was failing constantly, but it was a relief learning that VasQ had an option for me that I could get a successful one going.
What made you decide to give fistula creation one more try when your physician suggested VasQ?
It was honestly just, I would have to say, my surgeon's persistency on telling me how it would be good to just give it another chance, and how if it worked this time, it would actually be beneficial for my health.
What was the process like from the surgery to having a fully usable access?
Oh, so the process was I don't really know how to put it into words, but um, it was kind of difficult, but also at the same time not really easy. It wasn't extremely difficult because my surgeon, he actually made everything understandable and really easy to go through. But at the same time, it was hard having to go through everything I went through because of all the surgeries and all of that.
How did being CVC dependent affect your lifestyle and emotional well being? Did you ever have or were concerned about the possibility of infection? How has this all changed since getting the VasQ?
So it's changed mostly by me being able to depend mostly on myself now for my hygiene. My emotional state has actually gotten a lot better too, because again, I can take care of my hygiene better. I can take care of myself. I can do a lot more things. And I also, going back to the beginning of the question, I was worried mostly about the infection because the catheter is an open site mostly, and it's just, it hangs out of you. Like it just like hangs right there. And so when you have a catheter, you can't really do like water activities, you can't really lift anything, you can't do any gym activities really. And you have to worry about dirt getting in there, you can't wash it or nothing like that. And without it now I can do everything I couldn't do.
What does having a working fistula mean to you as you look forward to a kidney transplant?
Honestly, it means having a lifeline. It means I'm closer to being on the transplant list. Well, I'm already on the transplant list, but closer to being like further up the list.
And last question for you, Eileen. What questions would you encourage other patients to ask their doctor if they are considering VasQ?
I would just mainly have them ask, like, how is this beneficial to me? How can this ensure my fistula to work? Those kind of questions.
Eileen, thank you for sharing your journey and your experience with VasQ. Your story offers hope and encouragement to so many patients facing similar challenges. Finally, we are joined by AAKP Ambassador Terry Litchfield. Terry is a longtime patient advocate who served as care partner to her husband Bill for 46 years as he managed kidney disease. Bill was a founding member of AAKP and one of the 4 patients who testified before the House Ways and Means Committee, including one who dialyzed in front of Congress to help pass the legislation that created the Medicare ESRD program. Today, Terry serves as president of Access Solutions, a consulting service focused on patient advocacy for vascular access. Hello, Terry, and welcome to the program.
Thank you so much. I'm so happy to be here. So it's always delightful for AAKP to develop all these new programs and for me to be a part of them. Thank you.
Terry, as a former care partner, what were some of the biggest challenges you and Bill faced in managing vascular access over the years?
Well, I have to say, as I think back many years ago when we were newlywed, I didn't realize that dialysis access would break. I didn't realize that you had to have repair and maintenance. We had only been married about a month when he had a graft in those days and it clotted. And I didn't realize you had to go to the hospital. And so all of the things that nobody really ever told me, and I was in healthcare, I just didn't realize how impactful vascular access would be on not just him, but on me. I would have to take the day off of work. You had to, in those days, I remember it well, we had a $500 copay for surgery. And then you had recovery. And it just so happened in that first event, they put an access in. We went 2 weeks later to the surgeon and it had already clotted. And the surgeon didn't blink an eye and said, "Oh, this one's not going to work. We'll schedule in a couple of weeks for another access." And I almost fell off my chair. And so from a patient perspective, from a spouse, a caregiver perspective, it was very interruptive in our life and frankly in our pocketbooks and our budgets.
How do you think a technology like VasQ might have changed your experience as a care partner?
Well, I can say new devices, innovations related to vascular access occurred quite a bit in the 35 years I was married to Bill. And each and every one brought improvements, whether it was going from the old generation grafts to fistulas that had much longer life. They didn't have to have quite so many procedures after they were working, but also things like VasQ innovations, when they are able to relieve the patient burden and improve access outcomes, reduce interventions, it is so wonderful for the patients and the family. And so I think that any of the innovations that are coming down the pipeline are really good for patients, and they are all designed to improve outcomes and to help the overall health system move better.
How can patients best advocate for themselves to make sure they are aware of all their access options, including options like the VasQ?
Well, one of the most important things patients need to do is to be active and alert and involved in organizations like AAKP, where you will hear about new things through things like their innovation series. But also be alert. Sign up for the listservs from some of the social media and also LinkedIn, and put your access as vascular access as one of your groups you're interested in seeing things. And then when you are curious about something, when you are thinking about, or you've been told that you are on the last legs of the current access, or maybe you've got a central venous catheter and they're looking to give you a permanent access, write yourself notes, bookmark, print out things so that you'll remember them when you do go to the doctor. You have to advocate for your partner and for yourself.
Terry, what key questions should a care partners be asking their loved one's care team when deciding what type of vascular access is right for them?
Well, one of the best resources you should always start with, AAKP has online and available in print an access kidney options brochure that's easy to read. It's got lots of pictures in it. Be familiar with the 3 types of access: fistula, graft, central venous catheter. And ask yourself, what are the things I would want to know? For example, if your care partner to someone that loves swimming, well, you would ask, with a central venous catheter, can they still swim? Which that's probably not going to be a reasonable option always for patients. But make your list of questions. And it's sometimes hard to determine what to ask. And so sometimes just an open-ended question. You have talked with me about my husband's need to get a permanent access from the central venous catheter. What do you recommend and why? A simple question like that goes a long way.
From the care partner's perspective, what advice do you have for healthcare providers to better support patients in understanding their access choices?
This is a tricky question because there are many times that we perceive that a care provider isn't listening to us, that a care provider might have his algorithm or her algorithm for AV access. And so it is prescriptive and directed. So we're going to schedule you for a new AV fistula, and we can do that next month. And it doesn't collaborate with the patient. And I always remind patients to remember that nothing about me or to me without me, because it's really important that you have a care provider who will have open dialogue with you, especially about important issues like vascular access.
Terry, how can providers encourage shared decision making so that patients and their family members feel confident about their vascular access plan?
I love being able to give counsel to providers. And I think it's really important that you not start with, oh, do you have any questions? That is always something that would cause me food for thought. If I don't know what you're talking about, or I've never had a fistula, for example, I don't know what questions to ask. So one of the things I try to tell providers and care teams to do when you're having a truly open dialogue with a patient, educate them first, have materials, explain what you're going to do, what you're suggesting, and what the options are. And then you can ask them if they have any questions. And if they say no, they often have questions, but they don't know how to ask it, or they don't know what questions to ask. And so often if you were to simply say, a patient who's going from a catheter to a fistula often asks, how long is the surgery? How long will I recover? Will there be a scar? And so suggest questions to them and then answer them. And that will typically get the dialogue started. Don't assume just because a patient says they have no questions or their care partner has no questions doesn't mean they don't have questions. They just may not know what questions to ask.
And last question, what excites you most about the future of vascular access innovations and how these technologies may improve quality of life and health for patients on dialysis?
I love this. I love this because over the last few years, since the Advancing American Kidney Health executive order was signed, I have seen so many new innovations come to help dialysis patients. We've seen new catheters, we've seen percutaneous fistula creations, we've seen drug coating balloons to reduce the number of procedures needed on a fistula or a graft. And now there are new surgical options. There are a number of new technologies that have breakthrough status at the FDA. So we will be seeing them in the coming years. And so it's very exciting as a patient advocate to see so much energy being given. And so for patients, the future for vascular access, I suspect, will look very different than the past even 50 years.
Terry, thank you once again for sharing your deep experience and perspective on dialysis access. We are grateful for your ongoing leadership and advocacy. Thank you to all of our panelists for sharing your time, expertise, and personal experiences with us today. Your insights help empower patients and healthcare professionals to make informed decisions about dialysis access, a decision that truly impacts quality of life. If anyone watching has additional questions for our speakers or about today's webinar that we were unable to get to, please email us at info@aakp.org, noting the webinar title in the email subject line. In closing, if you are not already a member of AAKP, we encourage you to join. AAKP offers free membership to patients and their family members, as well as living kidney donors. To become a free member, join online at aakp.org/join or by phone at 1-800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified about all of AAKP's upcoming events, the latest in our educational program series, and when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the independent patient voice and change status quo kidney care. You will also receive a digital subscription to our bi-monthly magazine, AAKP Renal Life, and can select to receive any of our 5 different electronic newsletters, all for just signing up. We also invite you to check out our blog to read some great articles and patient profile stories, and follow us on social media for all the latest news and to keep up on what's trending. AAKP is dedicated to helping kidney patients across the disease spectrum understand their condition and take control of their healthcare. We are proud to offer a variety of resources for both patients and care partners. By visiting our website at aakp.org and clicking on the AAKP store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download free of charge, including titles such as the Understanding Your Hemodialysis Access Options brochure or the Conversation Starter, Questions to Ask Your Healthcare Team about choosing the right therapy for you. The AAKP All Kidney Policy is Local campaign is still going strong, and your voice is needed. Every message we send helps remind policymakers that kidney policy decisions made in Washington have real consequences for people in their own communities. It's not too late to get involved. Join us, take action, and make kidney policy personal. Contact me, Jerome Bailey, at jbailey@aakp.org to learn how you can participate today. And finally, check out our bit.ly/AAKP on demand to watch inspiring presentation from past events and explore even more great educational content on our AAKP YouTube channel, bit.ly/AAKP YouTube. We would like to extend a heartfelt thanks to our webinar speakers, Tammy Gilon, Dr. Keith Ozaki, Eileen Dion, and Terry Litchfield for graciously participating in today's HealthLine Innovator event. Their expertise and insights greatly enriched the discussion and provided valuable information. We also want to express our gratitude to Laminate Medical Technologies for sponsoring today's webinar. Thank you again for joining us. We look forward to you joining us for another HealthLine event.